Thank you for joining us today for a panel discussion on the Medicaid reforms and the budget reconciliation bill. Our panelists today are Medicaid policy experts, and the conversation is really designed with the operational challenges of the Medicaid MCO model in mind. But first, I'd love to introduce you to our panelists. First up, we have Allison Reiser, who goes by Allie. She's Executive Vice President of Payer Solutions at ATI Advisory. She's a health policy professional with over 20 years of experience in healthcare with specific expertise in Medicare and Medicaid programs, managed care, system improvement, long-term services and supports, and program integration strategies. If that weren't enough, Allison is interested in strategies to improve delivery systems and access to healthcare, with a particular focus on historically marginalized populations, as well as individuals with complex medical, functional, and social needs. Thank you for joining us, Allie. Our next panelist, John Gorman, is returning to the Agilion webinar stage. John has an extensive history working with and for medically underserved populations. Currently, he serves as chairman of Nightingale Partners, the nation's first VC fund dedicated to social determinants of health. John also serves on the board of directors of the Henry Ford Health Systems Health Alliance Plan and on the board of Round Trip, an innovative, non-emergent medical transport company. John also provides strategic advisory services to Epicure, a leading food as medicine company, and to Upside, a senior housing firm. John, it's great to have you here again. Rounding out our panel, we have Morgan Craven from ATI Advisory. Morgan brings 10 years of experience advising clients on Medicaid innovation and delivery system reform, federal and state legislative and regulatory analysis, managed care innovation, incentive payment programs, stakeholder engagement, and project management. Morgan has supported states across the country on Medicaid reform and will bring a state-focused perspective to our discussion. Welcome, Morgan. And last but not least, I am Trudy Loper. I am from Agilion and joining as your moderator. My background is in healthcare marketing communications, and I've worked extensively with industry leaders, nonprofits, and government agencies to navigate complex health policy issues and offering insights into the intersection of marketing, communications, and healthcare access. My role and goal today is really to facilitate an energetic discussion with our panelists and to provide critical perspectives on how the reforms in the federal budget reconciliation bill will shape the healthcare landscape going forward. This isn't just about policy interpretation, it's about what to do next. The key question is, how does the Medicaid ecosystem, and particularly Medicaid MCOs, adapt through these changes rather than simply react to it? We will be doing a couple of live polls today through the session, so just be on the lookout for those. They'll happen about midway through and closer towards the end, and so we will share a little bit of that as well. To set the stage, let's just review at a high level some of the key changes to Medicaid in the current bill and how our audience is feeling about what's coming. So we can go to the next slide. Thank you. The high-level changes that we know of within the bill as it stands today are those around eligibility changes, including how frequently address verification and enrollee status checks have to be done, as well as more frequent redetermination checks. There's the addition of work requirements, the immigration rule that would limit Medicaid to those with verified status, cost-sharing expansion, moving more onto our beneficiaries, a rate cap, and provider tax freeze. So within this, we wanted to get a feel for where you all were coming into this conversation, and you being the registrants. And we did ask a couple of survey questions within the registration that you filled out, and really appreciate you filling those out before coming in. We wanted to share kind of the mindset, an answer to the question of how concerned you are about the impact of the Medicaid change relative to your business or your industry. Overwhelmingly, we're seeing that people are concerned. About 60% of you are very concerned, 19% moderately concerned, and there's several of you that are waiting to see, which I think is a good place to be since things are changing so frequently. In terms of what your biggest concerns are about the proposed Medicaid changes, this was something where you could answer more than one, and here we're kind of seeing this break into two key categories. There's kind of the strategic planning up front around how to effectively plan with all of this policy uncertainty that's going on that we're going to talk about today, as well as how you prioritize your outreach efforts. But there's a huge component here around those potential outcomes, the losing members, the disruption to member continuity and care. Like, how do you plan for that operational and staffing strain, as well as the unpredictable revenue that's coming forward? So one last thing, we just wanted to look at the timeline, which is exceedingly fast for how quickly Congress is trying to get this bill through. Currently, we sit at the Senate is reviewing this against the Byrd rule. They will be taking a vote, and the goal is to have reconciliation between the House and Senate versions of the reconciliation bill completed by July 4th, which is really aggressive. And we're seeing even new news today from the CBO's office on that as well. So these changes signal a significant shift from member growth to eligibility defense and member continuity. With this in mind, I want to dive into the discussion, but first I did want to flag just the news from today that there were new numbers released from the Congressional Budget Office this morning.
Perfect.
What's that?
Perfect timing today, having this
Yes.
today. Yeah.
Yes, and also terribly devastating that 9 million people are projected to lose Medicaid coverage, another 6 million via ACA, and they're projecting 84,000 additional deaths per year and an additional $2.5 trillion added to the federal debt. So kind of the opposite of what we're being told in the
Well, and
market.
Trudy, I think it's important for us to also look at what's happening adjacent to Medicaid, because this will also have huge impact on plan operations and the impact on providers. This isn't just cutting Medicaid and ACA subsidies to fund a billionaire tax cut. This is an all-out total war on the safety net. Not only are they cutting over $700 billion out of Medicaid over this next 10 years, they're taking $320 billion out of SNAP or out of food stamps, which is going to reduce, according to CBO's report this morning, the average food payment monthly to eligible beneficiaries will go down from $26 to $10 per month. I mean, nobody can live on that. We know that this administration, through the president's executive orders, banned DEI across the government, but what that did was allowed the Doge kids, the Twitler youth, if you will, to just slash and burn the staff at all of the agencies that I think all of us on this call really care about. At HHS, they took out 20,000 staff. Right in my neighborhood, and where Ann Tumlinson, Morgan and Allie's boss, lives, 1 in 4 houses in our neighborhood is up for sale right now here in DC because of these cuts. Social Security Administration took about a 40% cut to staff. HUD got slashed, VA got slashed. The Department of Agriculture's food program staff got just virtually decimated. And the exodus from the CDC, which included everybody working on the Ryan White AIDS funding. Then if you drill in just a little more, if you'll indulge me for just 1 minute, one of the first things that they eliminated was CMS's Health Equity Advisory Committee, which wasn't just advising on the health equity measures in Medicare Advantage stars, but they were advising on measures for measuring quality in Medicaid and the exchanges as well. We saw the elimination of the social needs guidance for Medicaid when these guys took office, and rescinding the HRSN waivers that 26 states have right now to provide social health services through Medicaid to beneficiaries. So, I mean, we are looking at 15 million, according to CBO, losing their health insurance. And the terrifying thing about this for our listeners is that over 40% of Medicaid beneficiaries reported yesterday they have no idea these cuts are coming. So it's really important that we keep talking about this stuff. The low-income heating assistance program got decimated. That's 16 million seniors and duals rely on this to pay their utility bills in the summer and the winter. The Section 8 housing subsidies were decimated, and that's millions of people that depend on housing subsidies for where they live. I think it's reasonable to expect we could see a doubling of the homeless population in this country from about 780,000, which is dramatically undercounted already, to about 1.5 million as a result of this. So this is there's no other way to look at this than a broadside attack on the safety net that has to be considered in the context of the Medicaid and ACA cuts as well.
Thank you so much, John. I think that you jumped the gun on my first question, but I
Sorry.
would like to, you're great. But I would like to kick over to Ali for a moment, because John just gave us a lot to chew on. But from what your perspective, which of the proposed changes in the budget reconciliation bill are going to be most disruptive, specifically for Medicaid member continuity and or cost containment, and why?
Yeah, I mean, it's hard to pick with all of the things that you and John off. I mean, it's like all of them, I think, and I mean, to be clear, I mean, there are potentially some positive things happening in the background as well. There's a lot of disruption happening though. And it depends also in terms of like who you are as a stakeholder. So are you the person receiving the services and potentially losing the services? Are you a provider? Are you a health plan? Are you a state? So like provider taxes, managed care taxes that we're seeing both in this bill and coming through the administration right now, that's going to have a significant impact on states. So a lot of this bill is focused on like the expansion population, for example, but the trickle down effect of cutting state dollars is that states are going to have to cut eligibility and services for other non-entitlement populations as well. So there's definitely going to be a trickle down into the state space. They may push that to managed care plans. They may push more risk to managed care plans. Managed care plans may push some of that pressure to providers. We could ostensibly see some fee-for-service states start to explore managed care more seriously because they want to shift some of those risks off to other players.
Yeah, Idaho just announced yesterday they were thinking about it.
Yeah, I mean, I think that is definitely within the realm of possible. Like this is going to catalyze some states to kind of have to do that. Pass-through payments is going to be a huge one. Like that was, one of the things I think in your slides. It's going to affect providers' top line. If we now have a lower value dollar amount of pass-through payments going through to providers, which could mean harsher negotiations between providers and health plans. Specific to eligibility, though, the eligibility verification and the work requirements for the expansion population, one thing we're going to see is going to be delays in enrollment. So something that's different about the work requirements in this bill than what we saw the last go around is that this bill requires that a person has demonstrated that they've been working for a month before even enrolling. So if they haven't been, now we're going to have a delay at that point, as well as the ongoing sort of administrative ensuring that they're continuing to work. So that's one piece of it. The eligibility verification, of course, every 6 months, we're going to see people fall through the cracks. Like we did see this last time around, and it's in many instances due to administrative issues, not because they're actually not eligible for the program, but they forget to fill out the form or what have you. It's also very expensive to monitor and administer this. So I don't know the extent to which that like fed into the CBO reports, but for example, right now we have some programs that require work requirements, and we had them, several years ago. And per state, it can cost tens of millions to hundreds of millions of dollars to administer the programs. So I think it's important to realize that these are not without a cost, which means that it's not necessarily going to be successful at cost containment. I mean, it's going to be potentially successful at removing people from the roles, but not cost containment, because the other thing that happens when you're removed from the roles is you now have unmet need and pent-up demand. When you come back, your utilization is going to be even higher. And I think the other thing that I'll stop because there's so much that we could talk about here. But I think the other thing that's worth noting is that this is going to affect health plan risk pools. We saw that the last time around. We're going to see that again. And I think that's not something that's kind of in the mainstream being talked about right now. But if you pull people out who are in the expansion population, who are ostensibly healthier on average, not always, but maybe ostensibly healthier on average than the more traditional Medicaid recipient, your risk pool is going to shift dramatically, which is going to have an effect on your PMPM, like the state payments having to catch up with that shift in the risk pool as well, which means plans are going to have to be on their toes, thinking about like, how are they staying afloat, recognizing that the dollars coming into them do not necessarily match their current risk pool because those dollars were based on just a different population, an expansion population.
It's a great point,
places we could dig in.
Especially considering CBO says that as many as 1.5 million duals are going to lose their Medicaid coverage. So talk about an impact to the risk pool and the profitability outlook for these plans. I mean, most Medicare Advantage plans will tell you they make double the margin on duals if they're any good at population health. And
that can subsidize other programs and other populations. So that's kind of that trickle down effect as well. So it's a really good point.
So we're talking a lot from kind of the top down, and John raised a point a minute ago about, 40% of the Medicaid population doesn't know this coming. Morgan, I'd really like to know, from your perspective, what are some things that states can be doing, that MCOs can be doing to how can they communicate the coming impacts and how to prepare to their populations, from your perspective working with the states?
Yeah, so it's actually really reminiscent of the COVID days. When I think about what this looks like, it's when, oh my gosh, we need to communicate all of these changes that are happening to our participants and preparing for that unwinding. I remember there being just massive sort of technical assistance calls where there were MCOs and providers and states and CMS and sort of just other policy thinkers where it was like, what can we do? And so rather than recreating the wheel, I think it's important to base ourselves in what's happened before and really being able to assess what worked and what didn't. And then beyond that, going and being more innovative and creative, but understanding we just went through something very similar and we saw some really important lessons learned about what didn't work. And I think one of the important things there was MCOs need to be in lockstep with their states. Every state operates differently. Every state has different internal processes and teams and sort of values in terms of how it is that they communicate with their stakeholders. But it's really important in order to not be confusing and sending cross messages that may or may not be conflicting or may have different messaging and tone. It's really important for the MCOs to be partners in lockstep with the state. And so, MCOs, if you are if you don't have that kind of communication or strategizing happening right now, when it's appropriate, to be able to proactively outreach and say, we want to be a partner in this, here's what we're thinking, and be able to get some of those conversations moving, not just with the state, but with all of the MCOs in your state as well. This is going to be a really important effort to stay coordinated on.
Thank you. Allie, as we think about what's coming, what are some of the strategies that what should managed care organizations, what should states be doing to really prepare? More specifically, how do they prepare for retaining the beneficiaries? Because what I'm hearing is there's going to be a lot more work to do, administrative work, that potentially we're losing people who are eligible members. So what are some of your recommendations there?
Yeah, I mean, I like to start where Morgan was kind of going, managed care plans are such an important partner to states. They are a source of a lot of education for states because managed care plans have huge staff, right? And states do not have a lot of staff often running these programs. So recognizing the opportunity to educate states on what's coming down the pike, but also modeling out what the implications could be. Health plans are sitting on all of this data. They can take in this information and they can say, all right, looking at my population, looking at my claims, this is likely the number of people who are going to be affected. This is what that means in terms of top line, bottom line, risk pool, et cetera. So getting ahead of those conversations with states, again, especially now that Morgan mentioned, we have some experiences from COVID. We also have some experiences from the first Trump administration, building on that and getting ahead of this with some of that data and that information. But I also think thinking through if this moves forward, what does that mean in terms of, can you as a health plan use your value add benefits to address some of the service cuts that might be on the table for a state? Can you use your profit reinvestments? A lot of states will require MCOs to reinvest a portion of their profit into specific things. Even in states that don't require it, most MCOs do it. Can you use your profit reinvestments into the community, into things like the eligibility and enrollment infrastructure, into work programs, volunteer opportunities to help these people better meet these requirements, especially in work deserts or rural areas where there just isn't even an opportunity for someone potentially to meet these requirements? Can you invest in infrastructure in those areas? Can you stand up volunteer programs or work programs? In some instances, MCOs do this right now with other populations like the IDD, intellectually developmentally disabled population. Can you use that and expand that into these other populations? But also thinking through your care model. Again, risk pool is going to change. who's that going to be? What's that going to look like? Can you adjust your care model in a way? Can you work with the state to adjust requirements in a way where maybe you are bringing transportation services in to help a person with getting to the job and ensuring that the state will allow that? Are there language supports that you can provide so a person can retain 20 hours a week or 80 hours a month on average? Administrative functions, like we've got call center scripts, right? We've got engagement efforts. We have so many of those things that have to be under review right now. And like, how does that need to change so that we're ensuring that we're engaging people and we are, you know, ensuring that these individuals know that they have to be recertifying their eligibility, et cetera. So I think like high level, a lot of these areas where plans can start to lean in and educate states, bring some solutions to states, bring data to states, but also like if I'm a plan right now, I'm going to be looking really closely, like who's this going to affect? What's my care model? How's that going to affect like my services that I'm offering? How can I ensure I can still show up to retain as much of my membership as possible, but also like continue to serve them in a way that like my costs don't go through the roof. My healthcare utilization doesn't go through the roof all of a sudden because my care model doesn't meet this new risk pool.
And I think I'll add on to that, Allie, there's, I think, two things. One is the sharing of data. It's not just the education towards the state, which is very critical because MCOs have all of this data that states can't readily access and digest. So that's important, but there's also going to be that downstream connection to the providers who are interfacing with these individuals. You know, I'm thinking about a lot of FQHCs that play this role of really being the connector to the system for so many individuals. And oftentimes, I think right now we see there's a disconnect in data communication between plans and providers. And so if we can sort of open that up a bit more and have the plans be able to coordinate and say, here are the members that are at risk. What are you seeing on your end? That can be a potentially really effective strategy, especially for plans that are involved in some kind of value-based arrangement with those providers. It's going to be really critical, especially in those situations, that they can minimize disruption with those providers. And then the second thought, I love the idea that you're talking about in terms of how can plans actually help people meet these community engagement requirements. I think there's so much opportunity. This was something that I was thinking about when the bill came out, was how could we say, okay, we know there's so much unmet need in terms of community health workforces. And we also know that there's going to be a lot of people who are going to need to meet these kinds of requirements. And so, is there a scenario, for example, where even something like a buddy program for seniors who are receiving HCBS, something like that could meaningfully help keep people in the community, and it could also be helping people meet these requirements. And so are there really, strategic ways that they can not just check a box, but actually make meaningful improvements to people's lives?
I love that, Morgan. It's like a bent on peer supports. Like I way to think about it.
Yeah. John, is there anything you'd like to add to that?
Well, I mean, I think it's time to dust off the old playbooks from unwinding. I mean, if unwinding was a really bad hangover, this thing's an opioid overdose. This is going to be really a huge impact on health plan enrollment teams and the folks that have to do reconciliation to the one source of truth for the members' coverage. So, really investing in making sure that your enrollment and your call center and customer service teams have all the resources that they need at their fingertips, because this is going to feel a lot like unwinding, just at a much bigger scale. The other is, just kind of related to my comments from the top. I think Medicaid plans and Medicare Advantage plans serving duals especially really kind of have to think about benefit design in this environment and think about, in the broader context of this war on the safety net, what measures can we take to ensure we don't have a huge spike in food insecurity among our members, because that's the kind of stuff that lands people in an emergency room for multiple thousands of dollars admission when you could have fed them for $10 and kept them out of the ER. Transportation's another one, being able to get folks to dialysis regularly, or to, their oncology appointments if they have cancer. That ride is going to be multiple times cheaper than the inevitable admission and, frankly, the bad debt, if these people are losing Medicaid, that will occur at the provider level. So I think unwinding is going to be a good sort of training ground for this, but this is, this is an opioid overdose in terms of the impact on members. And I think what this is going to result in is just a lot of the Medicaid plans just kind of throwing their hands up saying it's got to be about margin over membership now, whereas before it was always about membership.
So that kind of turns a little bit towards my next question, which is really around how do value-based care models play into like mitigating this disruption? And specifically, are there any, how do you think states or plans should be adjusting incentives to stabilize access to care and maintain those outcomes amid eligibility churn? Allie, I wonder if you can tackle that first, and then Morgan, if you have anything to add from like the state specific, we'll just go through there.
Yeah, and I think I'm gonna like kind of pick up on a few themes that I heard both John and Morgan mentioning. I mean, one of the things that we have to think about now is like this could be incentives for a different population potentially. So plans may have, they definitely have in Medicaid managed care some sort of VBC models in place because states typically require it. They may require 50% of dollars or 50% of lives be in some sort of managed care, value-based care arrangement. Your population is going to shift, which means the model has to shift. It also means you need to be taking a look at your numerator and figuring out how many of the people I'm counting toward that 50% of dollars or 50% of people are in fact going to lose coverage. But I'm kind of wondering if there are incentives now for recertifying, incentives to deal with the effects of churn on utilization, and thinking of incentives not just as a like kind of a per click, per service type incentive, but like it could even be, we're going to staff you, hospital, with an enrollment liaison who catches people as they come in and either certifies them for Medicaid, and there are some vendors who are doing this now, but catches them and certifies them for Medicaid or ensures that they know that their Medicaid recertification, re-eligibility check is coming up. And like, how do you incentivize those types of roles that we've seen kind of around the edges, but not in a really
FQHCs too. Yeah.
That's a perfect one. Yeah.
Minority physician groups. Yeah, absolutely.
So like empowering them to play in this space too, because it's to their advantage to have people that they don't want people not having insurance. Like they want to get paid, but they also want to ensure that their patients are taken care of. And it's harder to take care of someone who's uninsured. I think too, though, it's like, are there value-based care approaches to member engagement? It's like, John, you started to go down this with like food insecurity and transportation insecurity. But like one of the things we haven't really talked about is the cost sharing requirements in the bill. And I don't have the exact numbers, but I think it was like $35 roughly for people up to 100% of the FPL. 100% of the FPL is $300 a week. Like, I challenge everyone on this call right now to think for a second and honestly answer, if you're making $300 a week, are you going to spend $35 on a cost share? Like, probably not. You're going to feel So there are other ways to maybe kind of waive that, work with your states to waive that, but accomplish the goal, which is member engagement in their care. So like one of the things that we've been hearing about are like decision support software. That's not new, but using that in a way with members to ensure like they're really a part of their care journey. And like, again, bringing that kind of into value-based care dollars to really encourage engagement. I think the one other thing I'll say, and then I'll be quiet, but again, remembering that it's like, it's not just about like the member retention, the person's experience. That's critical. The providers too, though, they are going to take a financial hit, and plans might as well, but they're going to take a financial hit if the pass-through payments are now lower. So can you use these models, again, if it's like giving them a staff person for like an enrollment liaison or whatever that means, like, is there a way to compensate for some of the decreased payment they're going to be getting? Because in some instances that could be them having to shutter their doors as well. Like we see nursing facilities closing, we see hospitals closing. So, really thinking about the ecosystem holistically.
One other thing I'd also expect to see, and it's kind of weird, but because of the massive cuts at the VA and knowing how many veterans also have Medicaid coverage, I think because they've gotten rid of a lot of the remote staffing for the VA that supports care, especially in rural and red states, I think Medicaid plans should start to expect a whole lot of out-of-network claims coming in from VA facilities, or a lot more utilization from those veterans who now can't access services at the VA and are now going to start hitting the ERs of your network instead.
And last thing I'll add on this item in terms of value-based care, the churn is just going to make this incredibly hard, where the financial incentives are going to start to get really jiggered up and misaligned. When you have continuity of coverage, it creates a more consistent long-term view of value. And that means that the MCOs, the state, the providers, everybody has, a vested interest in and understanding of how those payments flow and where those savings accrue and why it matters in that way within their value-based arrangement. But once you introduce churn and people start coming on and off, and the MCO, for example, doesn't have the authority to be able to continue engaging that member, but the FQHC that they're working with in that arrangement not only does continue to, but has to continue providing those services, it's going to create a really odd mix up in those financial incentives. And so I think that MCOs are going to have to be very thoughtful about what that looks like, what the impacts are, and how they can be a good partner to those providers, recognizing what Ali just said, that a lot of these providers are going to be facing pressures that they haven't faced before. And with these changes in care patterns, they're also going to have to be creating new investments to be able to care for these individuals differently. And so there's, your downstream providers are going to be having tons of upfront costs, lots of changes that are needed in care delivery. And there's also likely going to be impacts to the value-based care that they're getting.
Great. Thank you all for that. We have time for one more planned question. And one of the things that I know, John, you had raised when we had met ahead of this was really kind of thinking about, in the past, states have leveraged Medicaid waivers to meet the needs of the populations. What opportunities do you see states in using waivers in this future paradigm to really buffer the impact of these reforms?
It's a great question, because obviously the waiver process has been integral to how Medicaid has modernized itself over, the last decade or so. The new crew at the Innovation Center at CMS may be some of the more qualified people that we've seen in this administration of chuckleheads and Fox News hosts. These guys actually know a little bit about what they're there to do. I think the big question is, how far off the leash Dr. Oz and Secretary Brainworms is going to let them go. We know what they've already done, as I mentioned at the top, is that they already eliminated a lot of the Medicaid guidance around social health benefits, and they've made it very clear that, as I mentioned, the 26 states with the Herson waivers that allow for social health benefits like food as medicine and housing support, that the administration has said that they are not going to renew those waivers when they expire, but they will not terminate them mid-program. I saw somebody in the Q&A was already asking about New York's 1115, and I think it's safe for now, and that but they certainly will not renew it. Also, this war on DEI has really kind of gotten its hooks into the waiver process, because that's dampening down a whole lot of the more progressive stuff we were doing around social health, around new models for AIDS care, and sickle cell and things of that sort. Going forward, I think the waivers are largely going to be focused around what can be more efficacious. I think there's a lot of room here with this new crew around doing some real pharmaceutical benefit innovation. And if there are ways of getting drug benefits to be a lot cheaper, because that's a huge, huge portion of what Medicaid spends money on each year. I don't think we'll be seeing a whole lot of activity around the 1915B waivers around the freedom of choice and the home and community-based services waivers. That's just not what this administration is about at all. I think if we see it, we're going to see some crazy right-wing fantasy proposals for 1115 waivers. Like, we're already seeing some early conversations in a couple of red states where there's even discussion about letting like a private equity group come in and factor the entire Medicaid budget for that state. But in return, the state would have to hand over all of the administrative functions of the state Medicaid program to one of the portfolio companies of this private equity group. And then even conceivably disrupt competition requirements and issue a single monopoly contract to one plan to administer for the entire state. That kind of stuff is crazy to those of us that have been doing this for a long time, but in MAGA land, that sounds great to them. So I could see crazy stuff like that actually getting some traction with this office. The one thing I worry about with these guys is that the Innovation Center becomes a retribution platform against blue state waiver programs, and I think that's a reasonable fear in light of what we've been seeing from this administration. Allie Morgan, what would you add there?
I'm trying to reflect on, we work with a number of states, and what are some of the challenges that they're experiencing in real time, and what are some of the concerns and from both them and their stakeholders. I think there's a lot of broad community concern within the broader policy community. There's concern about the uncertainty related to a lot of these waivers. I think every single one of these conversations I've joined, that's usually one of the first questions we get is, well, what about our 1115? What does that mean? And so one of the things that I think is important for folks to understand is, I think 1115, like that, it's simply an authority vehicle, and it's become a really charged space in terms of how people are like, oh no, the 1115 is at risk. But it's important to remember that the 1115 is really just an authority vehicle. States use it as a way to obtain waivers from regulatory requirements, or to obtain essentially permission to have expenditures that otherwise wouldn't be covered. And so it's really, there's certainly a lot of shifts that are happening in the federal space. But I think as we think about partnering with states and what role MCOs and other providers and groups can play, it's really being able to communicate value, being able to communicate a really good coherent policy rationale for what you're trying to accomplish through those waivers, and being able to stick with those really grounded conversations to be able to make your case as to why these either waivers or expenditure authorities are needed in your state and can ultimately help drive down costs and improve outcomes.
I want to pick up on one quick thing, Tree. I know we want to.
Mm-hmm. Yeah, please.
John talking about CMMI or the Innovation Center. The other thing I think worth saying is this isn't about the eligibility conversation that we're having necessarily, but I fully anticipate this Innovation Center team pushing out more state models than we've possibly ever seen. I mean, they've said that in some instances publicly, like they are eager to push out more state models, more Medicaid models, work more with states, whether that's a whole model or like smaller waiver type pieces. But we could see more like of the ahead type things, like total cost of care, global budgets, in particular with a focus on managed fee for service. Now, if the person falls off the rolls, this is moot, right? Like there's nothing to manage at all. But and I know we're talking a lot about managed care too, but this could be an opportunity for managed care plans to be entities in this space, for states to be risk-bearing entities actually in this space, or for providers, of course, to be risk-bearing entities. We saw something at the end of the last Trump administration, the direct contract model, the high needs track was something that did not move forward. It would have been a managed fee for service model for dual eligibles. I anticipate something like that very much rearing its head in the near future. So again, not necessarily going to address people falling off of the roles, but will create opportunity for organizations like states or plans or providers to serve this fee-for-service population, the Medicare fee-for-service population, who happens to also be dually eligible in a more meaningful way, or do some more of these, like, again, kind of global budget, total cost of care budgets. So that's a whole other webinar in itself, but I do want to just note for the audience, like that, I totally expect is going to come down the pike. I mean, to John's point, like this is a sophisticated Innovation Center team.
Yeah. Well, thank you all for that. We've been trying to incorporate some of the questions into our discussion as we went. So we've had several questions about waivers. We've had several questions about, actually, Morgan, somebody was very interested in your buddy system concept and would love to hear more about that. Any questions that we were not able to incorporate, or if anybody has another question that they'd like to drop in the Q&A, please do that. But in deference to everyone's time, including both our panelists and the participants, what I will commit to is that we will capture all the questions, and we will be sending a summary of kind of some key insights and takeaways from this in the coming week, along with some segments of the recording itself. And if there are any questions that we didn't get to that were specifically directed to one of our panelists, we will definitely make sure that we follow up on those. One of the questions was about the CBO report. We will drop a link to that very shortly into our LinkedIn social. So I'm going to start wrapping us up because we're about 3 minutes to the time that everyone has committed here, including all of our lovely registrants. So before we do, I do a quick closing, I would like to open up to our panelists with one final question. So I'll ask you one at a time to answer, if you could leave our audience with one clear action or mindset for the next 90 days, really, what would it be in moving forward? And Morgan, I'd love to start with you.
So I will say, based on, there's been so much swirl. That's been a lot of the conversations I've been having with clients and with states, and it can be anxiety inducing, and it can also be really unproductive. So I know it can be challenging, but I would say, let a cooler head prevail, feel grounded, gain the information that you can gain, and strategically think ahead. But being able to take a deep breath and being able to actually think about how we can move forward in as productive of a manner as possible, I think is really what's going to serve people. So I realize that's a bit of a woo-woo response, but I think that a lot of parties are concerned about what the impacts are right now, and so I would say sort of be like the duck where you're sitting on the surface and maybe your feet are really working hard and paddling underneath, but being able to keep that calm center is going to help your organization and help the other people that you're working with to be able to work towards this goal together.
Thank you. John, how about you? What's your one thing?
I mean, certainly in the next 30 days, call your senator. Really, I mean, they are very sensitive to getting calls from not just their constituents, but from companies that are going to be impacted by these policies. So certainly in this next 30 days, bringing maximum political pressure on the senators. Don't bother with the House members, but certainly with your senators to make sure that they know what the impact of this will be. Over the longer term, the 60 to 90 day time frame, try to really maximize the budgets of the enrollment shop and your member outreach teams, so that folks, one, become aware that this is coming, two, what will be needed of them in order to preserve their coverage and avoid getting knocked off the rolls, and three, to remain engaged and not have any disruptions in their care, especially if they have multimorbidity that could really be impacted if they see any disruption in care. So that's what I'd suggest.
Allie?
And a little bit of both of those things. I mean, I guess my head is in both of those buckets. I'm a scenario planner. And I would say, like, yes, to where John is headed, like, try to educate people, whether it's your, senator, whomever, if you have perspectives on how this should change, like, think about ways you might be able to influence it, but also assume you're not going to influence it. And assume that you're going to have to operate in this space and start planning. Like, I don't know that organizations are going to be ready immediately to invest in things that they're going to have to pull the plug on if they don't move forward, but assume you have to, like, build out your, I mean, it sounds like, wonky, but build out your business plan. Like John's point, enrollment and engagement specialists, what does that look like? How quickly can you hit go on that if that moves forward? What are your talking points for your state? Build those out, like, model it. You're a health plan, you've got data. Right now, you should be modeling this stuff out. Certainly try to influence, but you've got modeling capabilities right now. Figure out what it all means and assume it's going to happen. And we're going to have to make the best of it if it happens, so that we can continue to serve people who are in, the safety net space.
Awesome. Well, thank you so much, John, Allison, and Morgan, for sharing your insights into both the current legislation as well as how we can prepare. And I think, Allie, that was great kind of to leave us with this scenario planning. This conversation is really critical to us and to our audience as we all try to answer, how does this ecosystem evolve and how do we adapt through the changes rather than simply reacting? So we would love having all of you back anytime. Clearly, we have several hours of content and a really engaged audience because the Q&A has been firing up. I do want to thank our audience as well, both those who were able to attend live as well as those who may be viewing this later. We will, as I said, share a summary of the key insights and actions from the discussion via email in the coming days. So just please be on the lookout for that in your inbox. And if you registered from your personal email, just make sure that you're looking out for that in your personal email inbox. This webinar was also recorded and will be shared either in whole or part on our LinkedIn page. So you can follow us at Agilion as well as on our website. And we will continue to follow the ongoing legislation, and we are looking to hold webinars in the future as major changes occur so that we can capitalize on things like the CBO office release of information today. Please do connect with us and stay in touch. And if you're ready to start tackling your problems now, specifically around member retention, please do reach out to me. I'm at tloper@agilion.com, and we'll get you connected with our team. So thank you again to everyone for participating, and I hope you have a wonderful rest of the week, and we will see you next time.